what to do in this problem. It's a big problem. First, the definition. This is a retinal break extending circumferentially 90 degrees or more in the presence of a posterior detached vitreous, rapidly developing an extensive retinal detachment with a tendency to rolling over an inversion of the rear giant retinal break, and is passing thousands of cells to the vitreous space, and that's the reason because they have high tendency to produce PVR in these cases. Before was considered a pre-VR status, the giant retinal tear. The surgical management still today is a challenge, just to reattach the retina. But we know if we reattach the retina, people can improve the vision to very good level. Even 20/20, we have many cases today with 20/20 after giant retinal tear treatments. Obviously, we need to pay attention also it's not a unilateral disease, so we need to pay attention in the fellow eye just to maintain fixed the retina because they have high tendency to the detachment. You can see here retinal detachments, and you can see here the PVD clearly produced acute many times, and this is the giant retinal tear. And you can see here is rolling the edges of the break and the tendency to fall over the retina. That's a typical image of the giant retinal tear. But the etiology of these cases, according to our experience, 50% are idiopathic, 10% trauma, and we have a lot of hereditary retinopathies, 10%, myopia, 25%, and other causes, 5%. The incidence is very low still, but this is a significant predominancy of males, 75%. The clinical findings are very interesting. In virtually all the patients in giant retinal tear, the tear is either partially or completely inverted, exacerbates if there is a posterior extension. When the posterior extension normally is folded over. The prevalence of the vitreous hemorrhage is quite rare, it's around 15%, but we can recognize normally with the scope the giant retinal tear. And the ultrasonography normally is not useful to use in these cases. Normally we don't need to use that. And obviously the key point is for the students, for the people who are at the beginning of the treatments in ophthalmology and retina, really recognize the two conditions, which can be confused sometimes. Then the dialysis, retinal dialysis, which is no PVD present, break at the ora serrata, you can see here the lines of the ora, and a chronic retinal detachment because fluid of the vitreous is passing here. Totally different than the giant retinal tear, which is the PVD present, it's a break, bigger normally, edge rolling over, and acute and fast retinal detachment, high tendency to PVR. This is no tendency to PVR, it's a high tendency to PVR and problems. We are going to analyze the different steps of the surgical procedure in these cases. In the vitrectomy, we must remove the anterior flap because this is going to be fibrotic and can create a new detachment. And we excise as much as possible this part of the retina anterior to the break. The vitreous gel is excised, avoiding to make extensions of the giant retinal tear. I think it's very inconvenient. Use the new vitreous cutter, which is producing less traction in the area of the breaks. It's a relatively new microincisional instrument. I think are very useful to do vitrectomy in these cases and remove carefully the vitreous gel and the peripheral vitreous gel. What's happened with the scleral buckle? Pars-plana vitrectomy was accepted for everybody as a principal maneuver, but this is sometimes combined or not with a cycling buckle. Most of the surgeons who don't do a sacral buckle use pars plana vitrectomy and normally perform laser 360 and then exchange gas or silicone oil. For me, it's difficult to determine the impact of the circumferential buckle in these cases in the final results, but seems to be better than pars plana vitrectomy alone, and they have much less reoperation. There are controversials in this point, but the current tendency is to place more buckles than before. And most of the doctors are studying to use different systems to place the buckle and don't spend a lot of time and less trauma to the eye. I'm going to change these systems, I think, in the next few years. Lens management is very important. In clear lens, you don't need to touch the lens, and normally with the new optic systems, normally we are using contact system. You can see more peripherally than the no contact, but there are excellent no contact systems too. But in traumatic cases with high myopia and with damage on the lens, the best thing is remove the lens. And especially if the patient is myopic, you can then correct with secondary lens when retina is attached. In the intraocular lens, we don't touch if he has a good position. But however, if they are associated with problem, it displays or is not in good position, or we cannot see very well, the best thing is to remove the IOL because it's a very severe disease, and the optics can be replaced afterwards. Probably the maneuvers to reposition the giant retinal wells was changing in the last 30 years, especially when Stanley Chan in 1987 is introducing the perfluorocarbon, and is introducing the perfluorocarbon for the giant retinal tears as first indication. I was lucky because I started to work with at the same time than Stanley. They give me the possibility to work with the perfluorooctane in Europe. The characteristics of the perfluorooctane make it the ideal for use in retinal detachment and in all the cases of with retinal problems. Of course, wide field system, which is completely in use today, is basic for giant retinal tear. And we inject a little bit over the optic disc and macula, avoiding damaging this tissue. We inject very slowly in the side of the optic disc, and we are feeling a little bit, and we are reattaching the retina from the posterior to the peripheral retina. And we surpass normally the level of the giant retinal tear to reattach the retina. Well, depend of the cases, we are using perfluorocarbon gas exchange or perfluorocarbon silicone oil. And normally when in small giant retinal tear between 90 degrees till 180, we are using gas in most of the cases, and you can reach a very good results. But in cases with big giant retinal bear, 360 or almost 360, or PBR cases, of course, is the indication is use silicone oil. One of the characteristics of the using of gas in this eye is slippage of the retina. But I'm going to show you how can you avoid that. It's not dry in the edge. That's not true. Probably performing fluid exchange. This is a typical 108 degrees of giant retinal tear, and we are removing first we can dim the lights a little bit. We are removing the vitreous gel and 360. We place a buckle, 4 millimeters buckle. I love to use 4 millimeters buckles in high myopic patients because it's covering much more part of vitreous vein, which is very, very weak in these particular cases. We can do more the lights. Thank you. And remove the anterior flap of the retina using 20 gauge instruments. It's like a little bit old, the video of it. Okay, you can use in 23 perfectly well. And we remove now all the gel, and then we perform fluid exchange. Why? We like to remove all the subretinal fluid in this space, because I think that some viscous subretinal fluid is attached many times to the retinal pigment epithelium and external retina. Is one of the reasons which is like a lubricant, and it's sliding. If you remove all the subretinal fluid, you have less chance to have sliding in these cases. And it's completely dry now. Now it's completely filled of air, and we grasp with a silicone tip cannula, and we aspirate a little bit, and we inject the perfluorocarbon between the two layers of the internal retina, and we inject a bubble of perfluorocarbon here. And now we extend the retina from the posterior to the peripheral. Now retina is reattaching completely. After do that, we can perform more vitrectomy in peripheral retina. Most of the people think it's not possible to use vitreous cutter when it's air in the vitreous cavity. That's a mistake today. Using the wide field lenses, we can remove much more easily the peripheral vitreous gel because it's compressed by the air, and we can see perfectly. And we remove the 360. Now it's completely filled of air, and there are some remnants of gel always, and we can recognize perfectly on the air. And using the new vitreous cutters, we can remove completely. There's no fluid in the retina. I think we lose some part of the. Maybe I lose some part. Well, at the end, I perform 360 degrees of laser, and I try to remove the vitreous gel, and I change the air by a mix of SFCs, the 25%. In another group of patients with bigger problems, we exchange directly the perfluorocarbon for silicone oil, avoiding the slippage, and in big breaks, I think it's better to use silicone oil. We are using always 500 thickness stocks because for me it's less problems inside of the eye. And we inject and reattach the retina completely with perfluorocarbon. We exchange directly with silicone oil, performing laser, surrounding all the. This is another case. He appeared in the clinic with vitreous hemorrhage, and so here you can see a tremendous vitreous hemorrhage. I place a buckle because I think it's a normal giant retinal tear, but when I removed the vitreous hemorrhage, I saw that. This is 360 degrees giant tear, which is quite infrequent. I think it's 1% or 2% of all the cases. And well, but we don't have any other solution to try to attach this eye, and we inject perfluorocarbon, and we open up the funnel. And you can see here, this is a wide field lens, but when we was injecting slowly, very slowly, it's important to inject and use perfluorocarbon liquid, perfluorooctane, which is the tendency to coalescent. The bubbles is much higher than other kinds of perfluorocarbon, and we reattach slowly the retina and working at low pressure on the eye, 15, 12, we avoid dispersion of the bubbles and avoiding passing to the retinal space. That makes very poor results many times because are sliding to the macula, and there are many techniques to remove perfluorocarbon under the macula, but I don't think they have very good results. I saw many in my life. Cases was treated many times outside of Barcelona, and they have very low vision, most of the cases, because remove the perfluorocarbon to retina space is not very easy. Well, okay, I replace all the retina, and I remove the peripheral retina, which is not working anymore, and then with a silicone tip cannula, I replace at maximum all the retina in the most extensive situation, because it's important to have more visual field in this particular case. So I place a buckle. I don't think if it has a lot of sense in this case, but in some part it's covering the edge of the break. I think in these cases perform 360 degrees of 3 rows of laser covering all the retina, since the peripheral to a little bit posteriorly, and then I exchange directly. This is a nice maneuver. Changing directly the silicone oil and remove the perfluorocarbon. I inject at the beginning of silicone oil, and then I am aspiration removing the perfluorocarbon, and you can see pulse the artery. And when you pulse the artery, you can remove a little bit, and then inject again, and remove a little bit, and inject again, and remove a little bit. It's very easy. At the end, you need to be careful to don't remove over the macula, to don't damage optic disc, because it can be incarcerate the retina, because you are working at high pressure. And it's very useful because you never have sliding using this technique. Retinopathy, as you told before, I perform 3, maximum 4 rows, and that's the typical case with posterior extension, PVD, as you see here, and it's folded over, and we use gas, buccal, gas, retina is reattached, and the patient is improving the vision many times 20/20. Well, postoperative complication, probably the most important is PVR. 14% is epiretinal membrane, so it's quite frequent seen, and it's a form of PVR, the epiretinal membranes, and in some cases have an increase of pressure and some decrease of hypotony. That's the typical case, was no buccal, no nothing, and big breaks temporarily. I think 2 nasal lip breaks are traumatic, iatrogenics, and then I place the buccal, reattach the retina. Retina was in the edge of the I perform a retinotomy 360 and inject perfluorocarbon and then silicone oil, and it's growing again PVR inferiorly, and I decide to use heavy silicone oil because it's pressing me. The new guys in the clinic are telling me, well, it's much better, you are getting older, and this kind of thing, but some days after you can see on the top and a PVR superiorly, and then I remove the PVR and reattach finally with silicone oil, and degree of hypotony, but visual acuity is 2100 in this particular case. Well, prophylaxis of the other eye is very interesting, very important, because there are many possibilities to have a detachment in the other eye and do laser, do cryo, or place a buccal in very aggressive cases, and that's all. Thank you very much. Next.
Thank you, Mr. Chairman. Thank you for allowing me to be a part of this. I would like to extend my welcome to all our visiting professors to Jeddah. and I would love to invite them to spend some time and enjoy the city. I will be talking to you over the coming few minutes on macular holes, diagnosis and treatment. By definition, a macular hole is a full-thickness foveal defect that extend from the internal limiting membrane to the outer segment of the photoreceptor. It is a condition that has been diagnosed more than 100 years ago by Knapp back in the 1800s, and at that stage it was secondary to trauma, and it was thought to be untreatable, and it stayed like this for decades. We know now that most macular holes are actually idiopathic. 0.05 is the incidence, with a slight female predominance. 15% of the cases are bilateral, and glaucoma is considered to be a risk factor. There's been a lot of pathophysiology behind the development of macular hole. We know in trauma, the concussive forces transmitted in a counter-coup is the culprit, while in most of the other idiopathic cases, it's the vitreous, with shrinkage of the perifoveal vitreous and adherence to the fovea that subsequently lead to hole formation. So the vitreous theory usually is the most common, and it necessitates the idea that there is anteroposterior traction with macular traction and cystoid degeneration over time that leads to hole formation. There's also the vascular theory that talks about the age-related vascular changes that end up with cystoid degeneration and hole formation. And there's the cystoid degeneration theory, where you get cyst formation and the cyst coalesce, and ultimately they develop into a full-thickness hole. As I said, 80% of cases are idiopathic, but we need to classify macular hole into primary and secondary, because we know that secondary holes do not do well from the management. Secondary holes can be secondary to high myopia, trauma, CME, choroidal neovascular membrane, end-stage proliferative diabetic retinopathy. This is usually a clinical diagnosis, and there is a good number of patients who, especially elderly, who might be discovered accidentally, but you would suspect a macular hole clinically. Now, for the sake of the residents, there is some few clinical signs that we use. The classical Watsky-Allen sign, where you shine the bright light, and the idea is to ask the patient what they see, and sometimes they even with the hole, they still see a full line. From the investigation point of view, there is the FFA and the OCT. We don't routinely do fluorescein angiography, but if you do fluorescein angiography, you commonly see an area of early hyperfluorescence corresponding to the window defect, while OCT is really a gold standard, not only in the diagnosis, but also in the staging and the prognosis of macular hole. Macular hole has been classified back in the 1980s by Don Gass, and at that stage he classified them into 4 stages. Stage number 1 is not a full thickness hole, and from stage 2 to stage 4 it's a full thickness hole. More recently, we've come up with an OCT-based classification. Now, in stage 1A, you lose the regular foveal depression with traction on the fovea itself, and this is the stage where you might confuse a macular hole with CSR or cystoid macular edema. And then this is just a schematic drawing. And then stage 1B is when you start to get some more adhesion and traction around the perifoveal macula, and this is where you get the essence of the deeper retinal layers, and you actually get a foveolar detachment. Once you reach stage 2, then you've got a full thickness macular hole that is less than 400 micron in diameter, with still some evidence of vitreomacular interface abnormality and attachment on either sides of the edge of the hole. Just showing the same. And stage 3, you get a full thickness macular hole that is more than 400 micron, but with still some attachment of the vitreomacular adhesion. And stage 4 is where you get a full thickness macular hole with a complete posterior vitreous detachment, even though we say there's around 40% of cases who might demonstrate the wise string, there is probably still some remnant or residual cortical vitreal attachment to the edges of the hole. From the OCT point of view, a macular hole can be divided into small, medium, and large, depending on the size of the hole. So if it's less than 250 micron with vitreomacular adhesion, it's a small hole. If it's between 250 and 400, it's a medium hole. And if it's above 400 with the presence of vitreous detachment, it is a large hole. There's something called stage 0, which has been recently described. It's an OCT-based description. When you examine these patients, they're usually normal, and stage 0 has been made to evaluate the contralateral eye of a patient who presents with macular holes. Since we said 15% of these patients are bilateral, the patient usually would like to know what are the chances of developing macular holes. So they look normal, they see normal, but on OCT they have oblique bands of vitreous attached to one or either side of the vitreous. This is a better photograph. In the differential diagnosis of macular hole, you want to consider pseudoholes, lamellar macular holes, cystoid macular edema, and VMT. Now, the management of macular hole has steadily increased over the past years. The success rate is definitely better, but I think the main question I usually like to face when I deal with these patients is to decide initially whether they should go for surgery or no surgery. We know from the literature that the duration of symptoms is extremely important. We used to say less than 6 months will have a better functional and anatomical results. We've extended the duration into 2 years, and lately we're thinking anything less than 3 years will probably have a better results. Yeah, I think the message here is that the long-standing macular holes have less anatomical and functional success, and this is extremely important to discuss with your patient before you operate on them. This is a prolonged procedure with subsequent positioning, usually an elderly patient. As I said, most of my patients are female and they're overweight, so it's very hard to ask them to position, and at the end you tell them the surgery did not work. Now, if we consider the OCT-based classification, if we have a small full-thickness macular hole with a small vitreomacular traction, you might consider pharmacological vitreolysis. For larger holes and larger areas of vitreomacular traction, I think surgery is the answer. Now, as far as pharmacological vitreolysis, we talk about the injection of Jetrea with the possible enzymatic vitreolysis of the vitreous. It is definitely an option for small holes associated with vitreomacular traction. The study showed that 40% have spontaneous resolution, non-surgical closure. In my personal experience, I did not see a major improvement with this. I have not personally tried it except once, and it unfortunately did not work. I still think vitrectomy is the way to go. There will be a room in the future, I think, for enzymatic vitreolysis, but maybe not at this stage. This is just a presentation of a patient who presented with a small hole injected with Jetrea and got better, and I think this is usually what the company like to show. Now, when you consider vitrectomy is the mainstay for the treatment of macular hole, you want to remove all the tractional forces around the hole. You would like to do a complete posterior hyaloid removal. You will dissect all epiretinal membranes, and there is the question of ILM peel. With surgery, the surgical success rate is around 95%, and the 10% failure is usually left for larger holes, stage 4, secondary holes like high myopia, or chronic holes. Now, the ILM represents the basal lamina for the inner retina, and it represents the scaffold for the proliferation of the fibroblast, the myofibroblast, and the retinal pigment epithelial. So removing the ILM will increase the likelihood of successful macular hole closure, but I think in macular hole surgery, you would like to be aware of the possibility of functional damage that can happen. Now, people have reported damage that happens not usually, not only immediately, but sometimes here with visual field defects. And I think it is something that you probably want to tell your patient about. So the question is to peel or not to peel. Since the introduction of ILM peeling back in the 2000, we've been running at this question. I think peeling a macular hole is different from peeling a diabetic vitrectomy. We know that diabetics are thicker while macular holes are thinner. So definitely it's an option. It will reduce the traction. It will minimize the hole recurrence. It will induce gliosis. So the general agreement is to favor peeling the membrane. And there's been a review that addressed the question of ILM peeling, to whether it will improve the anatomical and functional outcome, and it favors ILM peel. But I think the risks and benefits of such a procedure should probably be discussed with patients prior to attempting. And adjuvant dye is becoming an important part of macular hole surgery. As I said, triamcinolone is now used routinely because it will make the detachment of posterior hyaloid technically easier, but also the use of brilliant dyes which are safer. The use of ILM forceps in a pinch and peel technique would also make the surgery easier. You have all the possible availability for the tamponades, SF6, C3F8, and silicone oil. I personally try to avoid silicone oil to try to avoid second surgery. My personal preference is C3F8, and I know people use different tamponades depending on their experience. And as far as positioning, there has been a meta-analysis that was conducted over 4 clinical trials, and it compared the effect of face-down positioning, and they concluded that if the hole is less than 400 micron, maybe face-down is not necessary. I would have to say half of the struggle of macular hole surgery is in the positioning, and we do go through a lot of problems with our patients because most of the times it's a compliance issue, and you cannot blame them when you talk to a 60-year-old, with neck problems or back problem. It's not easy to position. The anatomical success rate is up to 90% without ILM peel. If you add ILM peel, you increase the success rate to up to 97%. So I think if a patient was done and the ILM was not peeled and they failed, then if there is a consideration of next surgery, is probably advisable to peel. And I trick I learned over the years is to do macular holes and not peel the membrane, and if it doesn't work, I send them with a note, peel the membrane. The techniques that has been proposed to improve the closure rates include laser photocoagulation, the use of transforming growth factors and autologous platelet concentrate, the extended ILM peel, the use of TanoBrush, and the inverted ILM technique, which I'll show a video in a second, focal retinal detachment, and the use of heavy silicone oil. These are all been advocated to increase the success rate of macular hole surgery. Now, there's been a lot of this is just to show the inverted ILM technique. Now people have advised inverting it. Yeah, okay. Into the hole, while others have just left it on top of the hole. You can shorten it, or you can leave it as it is. I think the whole aim is to gap that area of defect and hope that this will allow the closure of the macular hole. So in conclusion, macular hole repair must be tailored, and I think we've heard this a couple of times during today and yesterday. You really want to have an individual approach. I think with the advent of OCT and examinations and small gauge vitrectomies and dyes, I think we ought to examine our patients and classify them, and you want to treat each patient differently. I don't think there is a one treatment approach that should be advised for all macular holes. And when you consider surgery, I think the idea is to have a successful single surgery with the best visual outcome for the patients. Thank you very much. For those of you visiting Jeddah, we have the biggest bicycle in the world. So please get a chance to see. Thank you.
Mr. Chairman, ladies and gentlemen, it's an honor to be here this afternoon. I'm going to present our experience on ocular trauma and especially on post-traumatic endophthalmitis. With Professor Marco Zarbin, we prepared this lecture in memoriam of Dr. Cesare Forlini, who passed away almost 1 year ago. He was a great surgeon, teacher, an artist, and of course a great friend of many of us. So talking to incidence of traumatic endophthalmitis, we know that it's around 8%. So it varies, of course, but it's the mean incidence. And the key issue in the treatment of ocular trauma is to identify intraocular foreign body. If we identify a wound and the presence of intraocular foreign body, our strategy should, let's say, be focused on removal of intraocular foreign body. We know that retained intraocular foreign body is a risk factor of post-traumatic endophthalmitis, together with treatment delay, also nature of trauma, like trauma in a rural setting with organic material, with open globe wound, and of course wound localization in zone 3. So we know that incidence of post-traumatic endophthalmitis with presence of intraocular foreign body might be even around 50%. So we know that intraocular foreign body is a vector of infectious agent, also structural damage, and larger size and posterior location have worse prognosis. Also leads to PVR. Also we observe chemical damage like siderosis or halcosis, or damage of ganglion cells in animal models induced by zinc. So always rule out intraocular foreign body. Ultrasound is very good tool. We should perform ultrasound really gently, and especially glass and plastic. Intraocular foreign body you can detect with ultrasound, with wood, and vegetable matter is not so easy. We should observe sharp border suggesting presence of intraocular foreign body. Also, air can resemble intraocular foreign body. MRI is not recommended as a first line because you never know if it is ferromagnetic or not. But of course, CT with cut with less than 1.5 millimeters is the best method to start and to perform your let's say examination. Also, one should be aware that blood, drusen, or air may mimic intraocular foreign body. So sometimes really dense hemorrhage may mimic, may occur like foreign body. Also optic nerve drusen. Also some air bubbles may mislead our diagnosis. So in general, Professor Zarbin and his group performed a big study showing that altogether So CT scan is the most sensitive method to detect various foreign bodies, so glass, metal. So of course for wood is really difficult, and one should really also inspect the wound if there is a scleral wound, and if there is of course only a slight possibility that we have wooden intraocular foreign body, vitrectomy should be performed. So also localization is very important. So normally in anterior chamber it's easy to find the foreign body or the wound of the cornea, lens, iris with slit lamp. Sometimes, however, we have occult intraocular foreign bodies, but we should really inspect carefully anterior segment, looking for wounds in the anterior capsule, posterior capsule, or iris. Sometimes it is again necessary to perform CT scan. So a very special method nowadays we have in our hands, helical and spiral CT, which is a really sensitive method, more sensitive than axial CT or MRI or echography for detecting glass intraocular foreign bodies. Also, it takes less time and less radiation exposure. Also, it is very useful for elderly patients or patients with neck problems. We can see here on this slide foreign body. We couldn't find foreign body using slit lamp. It was behind the iris. However, with CT, it is easy to show the presence of intraocular foreign body. There are, of course, some limitations of CT, and like wood or plastic material may appear hyperdense or may be confused with air. Also, it might be difficult to localize intraocular foreign body as intraocular or extraocular if it is present and located near sclera. Also, size is very important and depends on minimum detectable size, depends on composition. So steel or copper, we can detect really small foreign bodies, but aluminium or auto window glass like 1.5 till 1.8 millimeter. And also wood is really, especially if the piece of wood is small, it is impossible to visualize. Again, also ultrasound biomicroscopy is very useful. It images anterior segment to 5 millimeters depth. Also accurately locates intraocular foreign body with respect to sclera. And using this method, you may find even glass or small pieces of foreign body in anterior chamber. This video shows the boy, 13 years old boy, who denied any ocular trauma. He came to the hospital with slight inflammation in anterior chamber and edema of corneal epithelium. After examination with CT, with also UBM, we found piece of glass in the angle of the anterior chamber, and it was possible to remove this piece of glass using vitrectomy forceps. Also, in such situation, sometimes it's really important to use a really proper instrument. In this patient, in another center, colleagues tried to remove piece of metal using just spatula, and they pressed piece of metal, so intraocular foreign body, to the angle. So the patient came to us with inflammation, with also we suspected siderosis, and using this special gonio lens, but and vitrectomy forceps, it was possible to find the metal, and also, but we had to perform cataract surgery. Sometimes it is also a really good idea to use intraocular magnet to remove such intraocular foreign bodies. In this case, this is a young boy, so he was injured with the wire, but the problem was that we expected that the wire also hurts posterior capsule or ciliary body, so that is why we were prepared to perform also vitrectomy if necessary. Normally in such cases we use vancomycin in concentration of 0.2 milligrams per milliliter in infusion line, and it works really very good. We don't observe any adverse effects, and so both to anterior segment surgery and posterior segment surgery. Sometimes we should look for multiple intraocular foreign bodies, so really check carefully scout film, and also antibiotic therapy is really crucial. We know that there are some so bacteria are really virulent, especially poor prognosis we observe after infection with Bacillus cereus or gram-negative rods. So here, for example, we have the patient infected with Bacillus spores in soil. So onset typically is after between 12 and 24 hours after trauma, with corneal ring abscess and also fever. Clostridium perfringens is also present in soil, and we see really rapid progression within 24 hours, severe pain, and progression to panophthalmitis. Are bubbles in anterior chamber, and greenish-brown hypopyon is typical for this infection. So we also use intravenously antibiotics like vancomycin, ceftazidime, intravitreal vancomycin, ceftazidime, and topical. Oral antibiotics, so systemic treatment nowadays, fluoroquinolones are really good medicine to use. Levofloxacin, 500 milligrams orally daily. Also, especially ciprofloxacin, if we have infection with Pseudomonas. Of course, they have also some adverse effects. In fungal infection, we use voriconazole, So this is a second generation triazole derived from fluconazole, and has excellent ocular penetration and really broad spectrum as compared to other drugs. So we may use oral therapy and also inject voriconazole intravitreally. Also, corticosteroids might be helpful in fungal infection, and typically we start systemic therapy between 12 and 24 hours after antibiotic therapy initiated, especially so for 1 to 2 weeks course. And of course, the crucial point of the therapy in traumatic endophthalmitis is vitrectomy. So we know that endophthalmitis vitrectomy study recommended prompt vitrectomy when intraocular foreign body was present, also with history of organic matter contamination. And if we couldn't see optic nerve head with indirect ophthalmoscopy. So in my opinion, my personal approach is immediate, complete vitrectomy with PVD, of course, except necrotic retina. We use vancomycin in a irrigating solution. We published this year big study on about around 40 eyes, showing that it is safe and effective procedure. Also, we use temporary keratoprosthesis and silicone oil tamponade, especially if retinal detachment is present. Professor Zarbin recommends as a first step, if view is poor, limited core vitrectomy without posterior hyaloid removal. If there is still inflammation and endophthalmitis, he repeats vitrectomy within 3-7 days, and he does not use antibiotics in irrigating solution. And he uses endoscope if cornea is opacified, and also he uses silicone oil tamponade when retinal detachment is present. So normally to start the procedure it is really not so easy, because every patient, every case is different. So we should, and most often also we have bleeding, huge hemorrhage, sometimes intraocular foreign body penetrates through the retina, choroid, and also sclera. So we should perform, I think, a big and complete procedure. And if normally, if there is really endophthalmitis, I do not perform ILM peeling. But if we have a chance to react really early and before inflammatory response, I always perform in trauma cases also ILM peeling to prevent PVR afterwards. So there are different approaches. Normally in young patients, I try to keep the lens, but let's say if, of course, there is a problem, the presence of post-traumatic cataract or lens is injured, we should perform combined procedure. Also, it is very useful to use endomagnet, endomagnetic forceps to remove metallic foreign bodies. It's very useful. Also, both in posterior segment and also in anterior chamber. But anyhow, we should perform complete vitrectomy. With in this video, we see that it is not so easy to catch the metallic intraocular foreign body. So this endomagnetic forceps is very helpful in this special condition. Sometimes also, we have really big injury, so the corneal wound, post-traumatic cataract, and intraocular foreign body. So we start from cataract surgery. We should immediately switch into vitreous cutter to avoid aspirating vitreous with phaco tip, and then we continue with posterior pars plana vitrectomy. In my opinion, in such cases, chandelier light is really useful, so we can use bimanual technique to remove metallic foreign bodies. So sometimes instead of forceps at this stage, we can use also endomagnet, but most often forceps are enough to catch the intraocular foreign body. Then of course we perform a complete vitrectomy with PVD and vitreous base shaving. And when if I have good condition, I also implant IOL. So in this particular case, we had central corneal wound, also with really dense post-traumatic cataract. So we start from cataract surgery, but lens removal is done with vitreous cutter. Then we see already inflammatory reaction in posterior pole and the metallic foreign body with retinal necrosis just nearby the fovea. So again, we try to remove intraocular foreign body using bimanual technique. Sometimes we should enlarge the corneal tunnel enough to remove intraocular foreign body. Then we perform PVD. In this particular case, I decided also to perform ILM peeling because of this necrotic area and also retinal wound to prevent PVR. And also in this case, after implantation of IOL, I decided to use silicone oil, also to prevent recurrence of endophthalmitis because of this necrotic area. Also, there are cases really dramatic when it's almost too late. In such cases, we use temporary keratoprosthesis to save the globe, the structure. So in this particular case, the first the eye was operated because of the glaucoma, also with Ahmed valve. Then it was injured with the wire, metallic wire, and rapid inflammatory reaction and endophthalmitis occurred, probably because it was tobacco wire, and so probably it was also organic material inside the eye and a really rapid inflammatory reaction. In this case, at least we could save the eye. I already performed like 50 cases with temporary keratoprosthesis, also in cooperation with Cesare Forlini and his group. We published the paper last year showing our results. Anyhow, to summarize, treatment of traumatic endophthalmitis is based on the diagnosis, then prompt administration of intravitreal or systemic antibiotics. In selected cases, consider antifungal agents, perform biopsy for culture, rule out intraocular foreign body with exam and appropriate imaging, repair rupture, remove intraocular foreign body if present as soon as possible. If no response to initial treatment therapy within 24 hours, reculture, perform vitrectomy, and repeat intravitreal antibiotic administration. Thank you very much for your attention.
We have a special interest in post-traumatic endophthalmitis. And about 6 years ago, we published a paper in which we reviewed 800 cases of open globe injuries. And we identified the risk factors for post-traumatic endophthalmitis after repair of the open globe injury. And the 4 risk factors that were statistically significant were presence of an intraocular foreign body, as you just mentioned, and delay of primary repair more than 24 hours, and dirty wound at presentation, and rural address, or a trauma that happened in a farm. Since that time, we prospectively injected, at the time of the primary repair, prophylactic intravitreal antibiotics at the time of the primary repair. And we used vancomycin and ceftazidime. And we recently submitted the manuscript, and comparing the two groups, we found a statistically significant reduction in the rate of post-traumatic endophthalmitis after we adopted this policy of prophylactic intravitreal antibiotics. So now we believe in our department that if a patient has risk factor for traumatic endophthalmitis, because the risk is very high, can be as high as 30%, it is very important and very crucial to give prophylactic intravitreal antibiotics at the time of primary repair.
Okay, thank you.
Okay, thank you, Boria. It's a great pleasure for me to be here. I'd like to present my experience about retinal membranes. I like to divide my talk in 4 chapters. First one will be about anatomy of this problem. The second one about how we can adopt new multimodal imaging in this problem. Then some prognostic factors, and then at the end, there are some steps about surgeries. So you know that the vitreous is unbelievable environment with multiple layers, with multiple pockets. And the vitreous has some normal physiological adherence. For example, one is behind the lens, another one is on the pars plana, the other one is on the optic nerve and on the macula. And getting older, the quantity of the liquid, the amount of water in the vitreous increase. Of course, this causes some lacunae, and we call this lacunae synthesis of the vitreous, and we cause also some contraction of the fibers of the vitreous. We call this contraction syneresis. And all these phenomena cause physiological posterior visual detachment. So it is very asymptomatic in normal patient, in a normal guy. In a normal patient, for example, it starts from temporal side of the macula, it proceeds to nasal side of the macula then will be detached by the vitreous, and then of course the last part that will be detached is from the optic nerve. And this is very important. This process can be very rough, very smooth, because you see this a patient with adherence on the vitreous. The vitreous was not very well detached. The patient who had some problems, some modification in the external part of the retina, with the external layers of the retina were modified. If the patient had anatomical, also functional problems, all these problems disappeared after the detachment of the vitreous. So, in the young, we have normal vitreous and vitreoretinal adhesion, but with aging, we have liquefaction vitreoretinal dehiscence, and we have the complete posterior vitreal detachment. Getting older, we have liquefaction without vitreoretinal dehiscence. We have this, we call this anomalous posterior vitreal detachment. And we can have the partial thickness posterior vitreal detachment. We call this vitreoschisis. And vitreoschisis can cause premacular membrane. And we can have centrifugal contraction with macular hole. We can also centrifugal contraction with macular hole and centrifugal contraction with the macular pucker. Of course, if you have full thickness but only partial posterior vitreal detachment, we can have a vitreomacular attraction syndrome. Also, we can have a posterior separation with peripheral attraction. In this case, we can have retinal breaks and retinal detachment. So this is a wonderful example of vitreoschisis. You see the posterior alloy is separated into layers. One is continuous with the retina. These layer can also give us some epiretinal membranes. So we have different aspects of the partial posterior vitreal detachment. This is a typical retinal surface after a completed PVD. You see the smooth surface of the ILM. Of course, in cell-phone maculopathy, we can have a disc-shaped vitreous cortex overlying the macular area. In macular pseudole, the vitreous is like a ring-shaped band around the foveal margin. In the macular hole, you have the disc-shaped vitreous cortex overlying the foveal area, but of course, the margin are attached of the fovea by its detached from its concavity. But we know that the formation of retinal membrane include also glial proliferation, which was considered some time ago predominant epiretinal. But with some more recent evidence suggests that we are also significant intraretinal components. So the migration of glial cells can be epiretinal but also intraretinal. This is typical specimen showing that we have glial cells on the both surface of the ILM, epiretally, of course, in contact of the upper part of the retina. This is why we remove many times both the membranes, the epiretinal membranes and the ILM. It was the case of macular pucker. We highlight with macular pucker with transimolon. This was a typical epiretinal membrane on the posterior pole. And then we highlight the ILM. You see the ILM with some dye like brilliant peel or some ACG. You see, it was a ACG. You see the edge. You see the edge of the ILM is here. In this over the macula, we remove together two membranes, epiretinal membranes, ILM membranes. This was the spec. You see the edge of the epiretinal membranes. You see the edge of ILM. Over the macula, we include in one maneuver both the membranes. So the incidence is about 62% of the population. That is 80% is idiopathic. But if you use a more accurate machine like the spectral domain of CT, the epiretinal membranes, the incidence is very high. It's about 34% of the population has epiretinal membranes. And the natural history is about 30% progress, for about 40% stable. This I don't know it's very exactly because I very rarely see regression of epiretinal membranes in my patients. So how can use multimodal imaging in this kind of problems? Of course, we have to highlight some structures in the retina. For example, the ELM. The ELM is the line of separation between the external part and the internal part of the photoreceptors. And you know exactly what is the RPE. So today we have to talk about ellipsoid zone. is a very hyperreflective line where the mitochondria of the photoreceptors are densely packed. And we have to talk also about the myotic zone. It's the zone with the mitochondria are less packaged. And also the interdigitation zone. The interdigitation zone is the part of RP, is the part where the tight junctions of the RP are very, very compressed. So, for example, using the M-phase OCT, you see in a preoperative period a large plaque of epiretinal membrane surrounded by retinal folds. And the postoperative, you can see for some time, of course, this aspect disappears with time, dimples, a rough retinal surface. Using adaptive optics, it's a normal aspect of corneal layers, a normal aspect of the mosaic in corneal layers. You see some microfolds in the fovea in patients with epiretinal membrane. You see the dark linear striae overlying the corneal mosaic. This dark linear striae decrease with the surgery. This is the aspect of epiretinal membrane in a patient with macular Parker. You see all the plexus of the vessels are completely disorganized. Also, the avascular zone is completely disappeared after epiretinal membrane. You see, this was the aspect before the surgery. You see the M-phase OCT and also the angio-CT. You see the irregularity, the distortion of the vessels in deeper and the superficial layers. After surgery, the complete restoration of the aspect of the vascularization of the retina, and also the restoration of the avascular zone. But nowadays, we can use the OCT intraoperatively. All the major brands of microscope are now embedded the OCT, starting from the Carl Zeiss with about 10 micro of resolution, arriving to the last model of Leica. The biopsy is with the resolution of less 4 microns. This is a typical case of epiretinal membrane with intraoperative OCT. You can scan all the area of the OCT, of the epiretinal membrane OCT. You can see also the effect of the forceps, the shadow of the forceps. You see the shadow of the forceps. You see how is strong your action, how is elastic the retina following your maneuver. The same is with the vitreomacular attraction. You see, there was a typical macular attraction. The patient was injected before with G3 with no effect. You see the effect of your cutter, how is elastic the retina. You see the traction, how is it strong. Maybe sometimes you can cause some break on the retina with this kind of traction. So, how can you use this system with prognostic factors? You know that, for example, we have observed to give a good prognosis to our patient some line. For example, the external limiting membrane, we talked about ellipsoid zone, we talked about indicated zone. And we can classify the grading of the ESOS zone. For example, this is a normal ESOS zone. This is only one abnormal ESOS zone. This is no ESOS, grade 0. And this can explain us how this difference in functional problems in this patient. These are the similar Parker, but with poor visual acuity because we have an interruption of ellipsoid zone in the left part of the slide. And we have a rather good visual acuity with same Parker, but with a good line of ellipsoid zone. When to operate, there is an homogeneous consensus to operate as soon as possible, at least if the patient has more than 20/40 of visual acuity. So we divide the surgical steps in some parts. First, corvitrectomy, then transition assisted posterior visual detachment, epiretinal membrane, peeling OLM using some dyes, and complete vitrectomy, check the periphery, and iris fluid exchange. I prefer to end my surgery with iris fluid exchange. So this is the typical aspect of using triamcinolone into different density. More dense to detach the posterior alloid. This was a posterior, it was a more dense triamcinolone. You see the typical aspect of a premacular pocket, the adherence of the posterior pole, and it was a very good method to teach to how to detach the posterior alloid in this case. In the second part of our surgery, we can use a less dense triamcinolone to highlight the posterior, the epiretinal membrane. See, this is less dense triamcinolone because, of course, we don't need many crystals or triamcinolone in this part. And in this case, you can remove perfectly with only one maneuver the epiretinal membrane, like in this case. Of course, under this membrane, you can find many times the ILM. So, we have to peel or not to peel the ILM. I like to present only one paper about more than 240 eyes. 100 with a single epiretinal membrane peeling, 142 with double peeling, RM at ILM. And the first group with single RM peeling, the recurrence of epiretinal membrane was about 60%. With double peeling, 0% of recurrence. So, removing the ILM, of course, you remove all the scaffold to the risk of the recurrence. So some tips. Of course, you have to sit, maybe, or you have to have a good hand elbow support. You have to use clear optics. You can use some more expert surgeon. You can use only the system, only panoramic system, or you use control system. You have to dye. For me, you have to dye. You can use ICG. You can use triple and blue, brilliant blue, or mixture and blue. You know the affinity of these dyes. For example, the ICG, the brilliant pill have a good affinity to ILM. Triple and blue have good affinity for epiretinal membrane. Some words about toxicity. The only substance which showed a great toxicity to the retinal components was ICG. It was toxic all concentration and exposure times tested. So choose starting point where you feel comfortable. Usually is close by your hands, of course, your dominant hands. Avoid gripping over macular bundle. A light grip, don't press. It's better to missing the tissue that grasps the retina. Pull and see. We call this pinch peel technique. And peel circumventally parallel to retinal surface. This is a pinch peel technique. It was a typical maneuver I showed you before. First, the triamcinolone to peel the epiretinal components. This was a less concentrated triamcinolone. It's only one maneuver for you was using the panoramic system. You have to focus many times with panoramic system, and you see this epiretinal membrane with only one maneuver. Then we use in this case brilliant peel, and then it's pinchable. You see, the first maneuver is to pinch and then leave the epiretinal the ILM. Then you have the fold of ILM, and then you can grasp the fold of ILM, removing safely the ILM without touching the retina. Conclusion. I think multimodal imaging can give us more parameters to give more good prognosis to our patient. I think we have to remove staining because I think you have to stain the ILM removal to remove ILM. The integrity of ellipsoid zone is the good and important prognostic factor. OCT, maybe during your surgery, can guide you to better results. Thank you very much for your attention.
Thank you, Dr. Izzo, for your talk. I think we have 2 questions, if we can have questions. I have one question for you. Definitely multimodal imaging did improve a lot of how we see the structures of the retina. It could be a predictor to tell the patients if he's going to improve or not. For one thing, do you think that the swept source is a better option, that we can see the ellipsoid zone, than to speak to the patients about their improvement and things like that? Or you think that regular OCT is fine with you now when you assess ellipsoid zone?
I think we don't know the importance of the choroid in this kind of problems because, of course, it can give us a very deep image of the posterior part of the retina. You can explore also the choroidal vascularization with the source. Maybe in the next future we will give more information also about from the web source. But I think we are enough today. We are enough to give a good prognosis to our patient. Of course, weight is no good in this surgery.
The second question is recurrent membranes. If you remove an epiretinal membrane and there is a recurrence, how long do you wait? Do you say there's a timing for maturity to remove an epiretinal membrane, or is there a mature retinal membrane, or if you see recurrence of epiretinal membranes, you go in and then you peel the ILM if you didn't remove it the first time?
Sorry, I cannot catch very well.
If you have a recurrent epiretinal membrane,
yeah.
Do you wait for maturity of the membrane, or you don't believe the issue of maturity of the membrane, then you go in and remove the ILM then?
I don't think we need the retinal membrane is mature today because now we have many dye agents perfected. We can see very well without also the membrane is very immature. I think I prefer to operate as soon as possible. Of course, we have the recurrence first of all.
Any questions?
So is there any special technique for that?
Sorry.
Fragile,
can you repeat, please?
Fragile ILM, so that when you are getting the first flap and that you cannot continue, feel that every time is getting small pieces. Is there any special maneuvers for that?
Are you saying about double dyeing? No, okay. After the first part. No. Yes. Unfortunately, many times you have to use more than one dye agent because many times you have a small piece of ILM, and in some patients, for some diabetics, the brilliant pill doesn't work very well. So you have to repeat the use of your agent. But so far we don't have any papers showing more toxicity if you use more dye during your surgery. I think it's better to avoid this many dye procedure. But anyway, I think it's better to remove everything that leaves something on the retina.
In patient with epiretinal membrane, after you peel the ILM, sometimes takes a long time for the macula to recover. Do you advise to give steroid at the end of the surgery? Do you think it will faster the recovery of the macular edema post-surgery?
Sorry, can you understand?
Repeat the question, please.
Patient with epiretinal membrane, after you remove the ILM at the end of the surgery, do you advise to give some steroid at the end of the surgery? Because sometime after surgery it takes many months for the macula to go back to normal. So do you think, in your experience, giving steroid will faster the recovery?
Yes. No, I understand. Usually, if in the preoperative OCT I saw macular edema with a large cyst, I prefer to use steroid at the end of my surgery. I use, of course, long-standing plant steroid. And I have a very good results with this because many times you resolve the problem, of course, the tractional problem, and you resolve the inflammation problem because, of course, long-standing membranes cause inflammation problem in the retina. It may be many times, of course, you have a good result, but macular edema still persisting after your surgery. When this patient, I always use long-standing steroid at the end of the surgery.
One last question.
Yeah, thank you for this very elegant presentation. My question, you mentioned that you do complete vitrectomy. You're still doing complete vitrectomy in case of macular pucker?
No, I check the periphery, of course, during my vitrectomy. I don't insist to the periphery, but many times you see during the vitrectomy, the peripheral vitrectomy, you see some traction on the vitreous. I call this the dynamic exploration on the vitreous, of course, because you don't see many traction if you observe without any movement. Of course, removing the vitreous in periphery, I can see you have some traction, and I will treat. My level of treatment is very low. I prefer to treat more with the laser than leave some Dubus area of the retina. And for this, with this maneuver, I have 0% of retinal detachment after my surgery.
I would really like to thank you for being in that prestigious meeting, and I would like to announce a change of my talk due to technical difficulties in presenting a 3D video. For example, if you were, do we have a projection here? Yeah, if we had this kind of video, you would have a double projection, and this is what you should see. But there's no way to have a projection for the 3D now. So in order to give you twice the same thing, I changed my talk into this, which is what's the use of the 3D surgery today? I come from Greece, from Thessaloniki, and my talk is changing to from retinal detachment to 3D heads-up, 27 gauge vitrectomy with ABUS 2 ingenuity system that our experience in Thessaloniki, Greece. And this is dedicated again to my close friend, late friend, Cesare Forlini, who was a mentor, a friend, and a great surgeon for about all of us. Unfortunately, I have no financial interest for this presentation. What about the feeling that you don't use binoculars? It's an exceptional thing, and I cannot put my glasses back when they fell down, because usually you put them glasses against the binoculars to put them down. Now with this system, you don't have that facility. But it's a very funny feeling not to have binoculars in front of you. But I'm going to show you just a clip of what we used to do without it. So we were perfectly, like Rijo showed you, comfortable doing all these things at the macular area without the need of an Ingenuity 3D system, because we had a wide field, indirect ophthalmoscopy, we can see these wide areas, and we have the help of the dyes, because there was a very low resolution to this. The low resolution was a problem for people that they are not used to dyes and to this thing. Can you? So we said that this summer we're going to get to ride a tough road, which is going to be the next step, off-road, off binoculars and back to the new system that is going to be. What changes the image that we have very good vision for that? First of all, it's the pixels that they didn't give us a good resolution. You can see here the pixels that when they come to 480 or LCD in the old days. And what is the meaning of pixelation? This is a very important thing, because everybody's talking about pixels. This is just how we can define pixels, by just changing the quantity of them. What is video microscopy? We know how we see. We know why it's 2020. But when you have a standard definition like our father's television or mine television, and you have a 480, your vision actually is 2100 when you look on your stationary on a photo, and it's 2200 when you look through the video. So if you're operating and somebody else is looking at the video, he has 20/100 vision, so it's very low, the resolution. What about the high definition that everybody has now? It goes up to 2040. You see the difference? Just by changing the definition from 480 to 1080 that everybody has now, it's 2040, the vision. So you're starting seeing much better through the television. And what is the wrong with it? You cannot have an enlargement of the visual field if you don't have 400, it's a small area here. Then you can go to 1080 and you get bigger, and now you have the 4K, which is 2160. With a 4K, you have the enlargement of a true wide field that you can have that. And it's coming, and I promise you it's coming, the 8K, which is going to be 4,320. And it's going to be just a huge screen in front of you that you can get into the screen and operate the eye. In conclusion, the beginning of something big. And I'm talking big because I am big. 3D machine vision is approximately the visual human acuity. We're approaching, we're not yet there. But the next generation, the 8K, is going to be, machine vision is going to be far more exceeding the human vision. So you have to be ready for it. It's not something. The next thing is how many tricks we can do with it, how many things can change our surgery. The one is that you can superimpose anything you have, fluorescein, angiography, OCTs, whatever, you can have on your screen. And they can direct you to do, where you do the lifting, where it's more lifted to pull the membrane, as Richard showed you. And then your assistant is not going to help you by pushing and pulling or holding the lens. He's going to hold a laptop, and he's going to enhance everything for you. If you need more light, you can raise the gain. You don't induce light into the eye anymore. You induce light into the TV, but you see better, and that's the more important thing, because all these effects are yours now that you didn't have before. And especially to my friend Riemann, who is one of my colleagues who's working with the 3D, the chips are less expensive than optics. So in the future, things are going to become less expensive to have a microscope or having chips. So chips are coming. We're not just starting now. We started 2014 with the first 3D course we had in, I think it was in London. And we started with Aberg and Riemann, and we started having the same course in Retina in Nice. Thanks to Borja, he gave us the lecture. And the last one was the evolution of 3D when we had to do it in Copenhagen. So the evolution was here. We started as a didactical tool, and we ended up with a surgical instrument. And what is the SASO doing? What is training doing to us? You can have artificial eyes, you can have the Ingenuity system, and you can train yourself in a wet lab. Like true-to-life surgery, because here you have the Haxwright microscope, the 3D Haxwright microscope. You have the artificial eyes, you can train somebody to do that. So training with the 3D glasses is a little bit important to understand, because not many people are used to wide-angle observation system. Finally, home means that Ingenuity came to us in Thessaloniki. And I still, although I had some experience in training in our school, I try to simulate exactly a surgery in my theater before starting to a human person. I would strongly suggest to do that. And with the artificial eyes we have artificial eyes where you can pull the ILM. So I tried to pull the ILM first in an artificial eye in my theater, and then we started the first case, who was a simple hemorrhage. So you have the depth to do that. What is very important that people don't recognize it from the beginning. When you have an operation, the only one who can see what you're doing is your assistant who's using the binoculars. Everybody else is looking through the video who has very low visual abilities. This time you're exposed. Everybody can see exactly the same as the surgeon, which brings to the theater that everybody is focused on the, and very interesting, your assistants, your nurse, they're not boring anymore. They get into the operation and they help you as far as they can, because they can see whatever you can see. And didactically, for example, if I do a surgery in the next room, everybody here can see exactly the same what I'm teaching. So it's an open border for teaching. And there are people happy at the end. And of course, I had a small video, one of my first cases, which is 27 gauge and a peeling of a macular hole. And you see I'm using 27 gauge vertically. You don't need to go, on the other hand, diagonally, because then you have a problem of squeezing them. You don't want to squeeze them. And it's very, very useful to see, even in 2D. This is a 3D. You can see it in 3D. Imagine in 3D. This is a 2D. And the other thing that's very helpful for those guys is you can get in and out of your 27 gauge without bending your forceps or whatever, because you can see much better. And as beautifully you can see here exactly in the macular hole, that the more macular holes they attributed to cortical vitreous attachment, that it's always fixed there. That's why it's very, very important to use Kenalog, because now you can see exactly what you're doing. But this is done from the TV set. It's not done through the binoculars. And it's exceptionally comfortable, because you're sitting comfortably and you work with it. And the next step is we use the finesse, which is the scratching element, in order to lift the membrane. Because the most difficult part in my hands is to start the peeling. We don't want to make any iatrogenic damage starting the peeling. So this is the lightest way you can start the peeling. We do it before and after dyeing. So you can see just a little flick of what is going on. You can see the white, and you don't move the pigment epithelium sideways, where you can have perimetrical damages if you do that, if you squeeze against the pigment epithelium. But in this condition, you can have the control, and you have the depth, and you have the resolution in order to peel such little tiny things through the camera. It's mechanical vision. And you see how comfortably you can pinch with 27 gauge, very small ILM in a hole. And of course, you can enlarge the view. You can magnify it as long as you like. And going through magnification, you don't lose the resolution. This is very important. Imagine they give you a place to get into the eye, and you don't lose the resolution. You don't lose the depth. I promise you, if we had a 3D now projection here, you can see the shadow of the vessels. And then, is it good with air? Because sometimes optical systems, when you inject air, they become hazy. Look through air. You go with a fluid needle near the hole, exchanging air, and then you see a little tiny flick of vitreous that was inside the hole coming out, liberating the hole. But all these minute details are happening in front of you with a lot of, I felt very comfortable, and I'm sure you're going to feel the same, because we are not different in comparison of technique abilities. So if I can do it, everybody can do it. But I'm showing you this on 2D, just to understand that everything is possible to be done. And at the end, you do a fluid exchange mixture that we use the valve, because they are unvalving the system for 27 gauge. And what is the major importance of 27 gauge for private patients? They go home the same day without anybody can understand that they did surgery. They don't have the asking question usually, what happened to your eye? It's funny, but it's good. It's nice nobody to be able to see that you have been operated. So some of the things that we mentioned, and is not in the program, is that one size fits all. I mean, you don't have to be tall, short, fat, or lazy when you sit in the microscope. You see small little girls to try to fit to the microscope, sitting down, up, and tensed. You put the patient where your hands are comfortable. So your size doesn't matter anymore. You have a huge thing with high resolution, and you don't need to accommodate anymore. Your accommodation doesn't play a role anymore. So you can easily adjust the zooming, and you can find the 27 gauge hole like nothing in the world, getting in and out without bending your instrument, especially the plastic tipped one, that when you go through a valve 27 gauge, so many times you hit the valve and you bend it, but not in this case. 27 gauge becomes big and easy, like Ingenuity is made for 27 gauge. I think that is the future. This is Thessaloniki. It looks like we still have some sea next to us that we can enjoy. This is the weather today. So I would much be here this night than going back to Thessaloniki. Thank you very much for accepting me.
Thank you, Dr. Nikolopoulos, for this great presentation. It looks like we're moving out of the optical visualization area to the digital visualization area. So what do you tell the whoever is going to be working with the system?
There is an echo. Voice.
What do you tell those?
To get comfortable. I show you all the steps. I show you my Q-Tison system. First of all, buy an artificial eye from our Austrian friends. I can send you the address. You can find my email and send me. I can send you the address of the artificial eyes that you can peel the ILM safely. So if you try to do that, to do a vitrectomy on an artificial eye, and you feel comfortable, not feeling anything, go to the patient. So it's a test to believe it. It's not a test to train yourself. You don't have, it's incredible, you don't have a didactical sort of curvature that you need to learn. But in order to persuade yourself not to endanger the patient, you need to do once in an artificial eye to see the maneuvers inside the eye, just to feel comfortable, and then you start. And the next thing that is very, very, very important to understand that is that you don't have to do it. But if you do it, you don't like to change it. You would like to have it. And this is a hook. And it's money again. It's more money. But new things are coming. This is the future. I'm hooked to it, and I wouldn't like to do it without. So my advice would be just to train a little bit. You know that ESASO has a school for training people. The young ones can go to ESASO. Let's talk about that. And we are open to any suggestion and any questions we'd like to have on the subject. Thank you.
The principle underlying all the retinal prosthesis is the replacement of photoreceptor function in patients with external layers of the retinal problems. This is a wonderful slide showing the three principal cells of our pathway, or visual pathway. For example, the photoreceptors, the bipolar cells, and the ganglion cells. So we have some illness in which the external layers of the retina are completely disappeared. For example, the retinitis pigmentosa, the Stargardt disease, some forced macular degeneration. This is a typical aspect of normal uterine retina on your left. You see the photoreceptor layer, the ganglion cell layer well represented. This is an advanced patient with retinitis pigmentosa. You see the complete disappearance of the photoreceptor layers and the hypertrophy of the layers of ganglion cells. So we have many studies about retinal prosthesis up to now. I'd like to present our experience with Argos 2 system from Second Sight, California. The Argos 2 system is composed by a micro camera on the spectacles. The micro camera, of course, receives information from the external environment, and it transmits by cable information to the microcomputer, video processing unit, which transform the information, the light signal into electrical impulses. And this transmits wireless to inductive coil, to an antenna placed on the sclera. And then it's connected with the case. The connects sent through this cable to the surgical implant sixth electrode on the macula of the patient. This is the new generation of the system. You see new spectacles, new VPR, new microprocessing unit with new software, with the capacity to face detect the face, to eye track with more depth information. So this is the internal part of the system. You see the antenna, the coil, the cable, the sixth electrode chip. You see the antenna is placed under the muscle, the rectus, external rectus. The antenna is very thick. It's connected with the scleral band you use normally with retinal detachment. So this is the maneuver. You pass through the external rectus. This I think was one of the more difficult maneuver because the antenna in some eyes are very short. It's difficult to place under the rectus. This is the art of the system. You see six electrodes well placed on the macula, on the posterior pole. You see OCT is well represented, the perfectly position of the system. And these are the tack that we use to fix the array on the macula. These tack are 20 gauge, are coming from old Macular tacks that we use now more than 30 years ago for giant retinal arteries. So the indication for use of this system is, of course, adult with severe to profound outer retinal degeneration, with some residual light perception, with previous history, of course, of useful form vision, with good cognitive skills, of course, good motivation. Good motivation of the patient or the relative is very important. The criteria are, of course, optic nerve disease, all the problem of the nerve, extremity conjunctiva, because in the first trial we removed some implant secondary to erosion of the conjunctiva. The length of the eye has to be included between 20 millimeters and 26 millimeters of length. Of course, all the cloudy media, which can prevent you to examine the fundus of your patient. This is the target, typical target retinal pigmentosa, typical illness with loss of photoreceptors. And in Manchester, Paolo Stanga started with dry MD. Paolo operated 5 patients. These are the first 4 patients. We are very curious to see these results. Paolo concluded this first trial with 5 patients last month. He will present some results next year, I think, in Floretina. So we implant for the first time, for the first patient with advanced Stargardt disease. The Stargardt disease is a typical illness, hereditary illness with complete disappearance of external photoreceptors. And it was the first patient we operate. So this is our experience with 25 patients. All these patients have at least 1 year of follow-up. You see the median age is very low, about 55 years. We start from 30 years old to 72. The follow-up is at least 6 months to 5 years. And the surgery time was from the first case about 4 hours to arrive the last case less than 90 minutes. This is our casuistic, our total surgery. You see the time of surgery was starting at 20 to 130 minutes to arrive at less than 2 hours in last case. We have only one severe complication, retinal detachment, complete inoperable, was a very severe PVR. We have some choroidal detachment secondary to the leakage from through the scleral wound. This was our first 12 patients. All the implants were well placed on the center of the posterior pole. This was one of the tests we performed to have some results from the patient. This test is square localization testing. The patient has to identify in the screen of the computer a square of 12 centimeters of the dimension. This is another test. It's a bar motion. It's a more difficult test because the patient has to scan with the direction of this bar. You see the pre and post-operative results. All these patients had very good results after 2 years. So after of course, beyond the functional result, we explore some other tasks with this patient. For example, sound localization. We know that all the blind people can lose the capacity to localize the sound. Where is the sound is coming? And this was, of course, this was an anechoic room completely isolated by panels, and the patients had to recognize where is the source of the sound. This was the results. This is the line of the control subjects. Of course, they can identify exactly where is the sound, the source of the sound. This is the patient. After some months, of course, they can recognize better where is the source of the sound. And then we carry out some functional magnetic resonance of our patient of 1.5 Tesla. You know that structural MRI reveals brain anatomy. The functional MRI reveals brain function. This was a typical control subject. Of course, this was the occipital area, the vision area, well presented after visual stimulation. This was a patient with advanced retinal pigmentosis with no area in the occipital part of the brain. This was our patient before the surgery, advanced, no signal of something in the occipital area. This was after 1 year. You see some areas, you can see some areas in the occipital part of the brain. You see another patient before the surgery, after 1 year, after 2 years. You see, you can have more area of visualization in the occipital part of the brain. Of course, this has some repercussion on the functional exam. You see the preoperative visual field after 2 years. You see some area also far from the implant. You can rejuvenate some area applying with this very low stimulation with microampere of energy. See another patient before and after the surgery. This I'd like to show some cases. It was a case before the surgery. It was one of the first cases, 2012. It was typical aspect of retinal pigmentosa with a very low thickness of the macula. This was the surgery. The surgery was went very well. This was a typical maneuver to tack in the posterior part of the retina with the bimanual maneuver. That the chip. You see the tack using tack in the silicone ring. It was a typical. See the position was very good. This was the aspect after 1 day. You see there's some spots of hemorrhage secondary to the pressure, the USS8 on the posterior pole. This was a good position of the array on the macula. And this was the energy that we applied to stimulate lights in patients. You see, we apply very low energy, under 240 microampere. You see, all the pixels were good. Only most of the pixels were good. Only 5 pixels didn't work at that time. This was another patient. You see the difference of the aspect of the fundus. The patient had a big staphyloma on the posterior pole. It was the surgery. Similar surgery was the surgery was good. At the time we were using a flute needle to hold the chip. Then we applied the tack on the silicone ring near to the posterior pole of the macula. This was the fundus aspect. After 1 day was wonderful, the aspect of the fundus. But you see the OCT was not very good because the distance of the chip to the macula was very high. This was secondary to the staphyloma of the patient. You see this was preoperative at 1 week. You see one side of the chip was not adherent to the retina. But the reason we apply, in this case, we apply more energy to stimulate the pixels on this side of the OCT. We have one severe complication. It was I'll show you this complication. It was a perfect surgery. It was last year. The chip was very well positioned on the posterior pole. You see, but we had some distance between because also this patient had the staphyloma. 1 week we scheduled the rehabilitation session, but after 3 months we have a severe case of choroidal detachment. You see, this was the aspect of the fundus. You see these big bubbles of corneal detachment covering the posterior pole of the patient. Of course, we operate this patient. This was the expected because the patient have a very bad hypotonia, and you see, we put some infusion in the posterior, in the anterior segment. It has also some luxation on the lens, but it wasn't a big problem. We opened the conjunctiva. We removed the patch we have used to cover the implant, and we saw a continued leakage from the sclerotomy, of course, because the sclerotomy was closed, because sometimes it happens because the cable is 5 millimeters. Of course, it holds the sclerotomy still open. We put some mattress suture and around the scleral wound, and we covered with another patch this wound. This was after 3 days. The reduction of the corneal detachment, the chip was very well placed on the back. So one of the problems, of course, is the cost. This implant costs about $100,000. So you calculate the power of your computer with MIPS, million instructions per second. Your computer is about 10 millions, 10 MIPS. For example, in 1980, at the time of IBM 1130, one MPS cost $1,000. So at the time was the equivalent of the brain of the world. In 2015, we have a computer with the same capacity of your brain, the capacity to decide. So in 2050, 1 million of MPS will cost $1,000. This is the evolution of technology. So another question is why we don't have more electrodes. The problem is the dimension of the chip. Because we have to do a 5 millimeters incision to introduce 6 electrodes. And you know that all the problems are coming from leakage for this very large wound. And the cable maintains this wound open. So, but if you see the difference between the 20 gigabyte of IBM computer in 1980, the difference with 32 gigabyte, maybe your phone has a smaller flash memory flash. So this was my last patient. It was Rossana. Rossana now she was completely blind. She can read Casa, home in English, in this computer at home. So this is a new version of this implant. Next year, of course, neurosurgeon will implant a version of Argus 2. We call this Orion 1 in the occipital part of the brain to stimulate visual acuity in patients without eye, with problems of optic nerve or problems with the eye. So, in conclusion, we demonstrate this surgery is safe. We have only one severe complication, a severe case of PVR. This was secondary. The patient was in pregnancy. And of course, we don't follow up for some months. The results are very encouraging, but the selection of the patients is very important. I think we began a very professional, a very personal, great experience. Thank you very much for your attention. We invite all you to Floretina 2017. The best retinal world will be there in Florence from 27 to 30 April in this year. Thank you very much for your attention.